commodity reporting. We really have had issues. We are hoping that we can be able to respond to issues here and see that improved. So Vincent, you will take this mic and continue.
Thank you, John, and thank you participants for attending this meeting. So I'm just going to run through what changes have happened on KHIS after we revised our KP tools to include the VP and also align to the changes in the HIV care and treatment guidelines. So to start with, you remember this was a consultative process, this process of tool revision. All partners and counties were fully involved in that process. And we had agreed that we were going to roll out the new KVP tool starting January 5. Is when we expected the first report of KP on KHIS, including VP and even the 731-6, the MAT reporting tool for those sites implementing MAT, and again the commodity tool, which again which used to be reported at sub-county level, was moved to facility level, just for accountability and making sure that commodities are properly accounted for. So this is the previous KHI structure where we used to report at sub-county level. You remember there was no need for the dice to be physically located in the sub-county of implementation. So at data entry screen on KHIS, you will log in at sub-county level, and then you will choose your dice. And remember, the hotspots being the basic reporting structure for the KVP program, then that means several hotspots for that program or implementing partner were aggregated and reported at sub-county level. Like if I may give an example of like Hoimas doing like 14 sub-counties of Nairobi, they could report at Starehe, Dagoretti, and even Madare or any other sub-county that they were implementing in, ensuring that, remember this could be acting like virtual dice. So there were a lot of unaccountability issues because now we, even when a county or a sub-county needed to do a DQ in the sub-county, they needed to move to the parent dice because all these records were kept by the parent dice, but the services were being provided throughout each models to those sub-counties. So again, commodity accountability became a challenge. So this is just an example of that model when we came now to the KHIS data entry mode. And you can see like Embakasi sub-county, you could just choose the sub-county and then you select the data set. Like for this case was like MH731 prep summary tool for the dice, and then you choose the date, you will choose the dice, like dice best molem, and then you continue with your data entry. But now, since we have changed that structure now to align to what other data sets on KHIS have been aligned to, so you realize that the hotspots remain the basic reporting structure for the KVP or KP programming, because we have other tools that are aggregated at hotspot level, like the hotspot listing tool, which aggregates all activities or happening at the hotspot level. Then these hotspots are supposed to be aggregated into a standalone healthcare facility or a standalone DICE. So we remember here now, it's a requirement now for KP data to be reported. Then you need to align to this, so that in sub-counties where this DICE is not physically located, then it means that they have to choose a facility, a healthcare facility, MOH, or government facility, where they need to migrate all their records to that facility, ensuring that all the KP records, including testing, including the files, are allocated in that facility for easier accountability, and again to ensure that we are reporting the service actually where the service happened, instead of migrating data from one sub-county to another. So you realize that once you log into KHIS, you come to the sub-county, then you go to ward, and then you choose the healthcare facility or the standalone DICE where the service is happening. So this is the structure as from January 2023. So several calls have been receiving from sub-county HRO saying that they can't see the data set. So the data set was revised, and it's now at facility level and not at sub-county level. So those are the changes on the structure. And this is just an example, like for the same case of Nairobi, you can see this is Molem Ward in Embakasi West sub-county, and then you choose the facility which is now Best Molem DICE, and then data entry continues. So what are the implications of this? So you remember for big facilities like sub-county hospitals, we have HROs who aggregate these reports and do entry directly onto KHIS. But we have some certain small facilities like healthcare centers or even DICEs that do not have data entry rights on KHIS. So what they do, they need to aggregate that data at facility level and submit the reports together with other reports like the MOH 731 comprehensive, the 717 workload, and even all other reports to the sub-county HRO for data entry onto KHIS. So these are some of the reports that the minimum level for KP programming that should be submitted to the sub-county HRO, or should be keen at facility level where these facilities have data entry rights onto KHIS. So we started with MOH 731. Remember, this is also comprehensive and revised 2023 version. And then we have MOH 731 plus summary for key population revision 2023. So any facility offering a KP program, then they need to report on that. Then MOH 731B plus summary for vulnerable population. So all sites implementing fisher folk, discordant couples, prison or inmates, and the trackers need to report on that. Then MOH 730B, facility consumption data and request report for antivirals. So this is all sites. Remember, condom reporting moved to this section. That despite a facility could not be an NRH site, but remember it needs to report condom, since condom is a universal commodity. And then we have MOH 739C. This now was majorly tailored for KP specific commodities like the needle and syringes and the hepatitis STI and hepatitis B drugs that we programs have been receiving free from NASCOP. Then we have the workload report. All sites need to do that. And then MOH 643B, all sites need to report on that. MOH 729B, this is for ART sites and DICEs doing ART needs to report on that. And then for MAT, we need to report on MOH 731-6. So that is for all MAT sites. So remember again, MAT was previously incorporated in the old tool. That is MOH 731 plus summary for key populations. But going forward, it was separated and are also aligned at facility level. So all MAT sites report at facility level. So the implication was that data data entry and reports mining on KHS was aligned as per the KHS structure. So that's in line with any other reporting or any other data set on KHS. So KP reporting was aligned. And in this structure now, dices are now healthcare facilities, or they are in that group of healthcare facilities on KHIS. So if you needed the data for a specific dice, then you have to select, you go to at facility level and not data concerning PEPFAR, data concerning Global Fund or Kenya Red Cross, then you are able to assess the data for the dices only doing per donor. And then counties where more than one IP is implementing in the same ward, where there will need to be proper demarcation to ensure that hotspots are properly demarcated, and this will be in consultation with the KP community themselves, the county teams, and the implementing partner. And KP commodity accountability then has become easy. Remember now, KP commodities from KEMSA are going directly to those facilities that are implementing KP and will not go to the parent dice, so that it can be distributed now to the other, or it can be distributed when you are going for your outreach. So you see that here that now all commodities that are usually given from NASCOP with respect to KVP programming will go direct to those facilities. And this will bring greater accountability of data from source to all healthcare records. And then healthcare, so the catch here now, healthcare workers in linked facilities. So these facilities that have been selected to be KP, to offer KP service, we need to make sure that health and also offer KP friendly services. Like in allocated, we have 300 of them being linked to GF for Kenya Red Cross dices, and then about 237 of them being PEPFAR supported. So in total, we have 537 facilities for KP, or that have been allocated data set for KP on KHIS. So if you could just brush through the current status of data as at 28th July 2025, starting with the reporting rates, and you can see we've really dropped. As at December 2024, we are talking of a reporting rate of 92%, as John had said earlier. But you can see nationally we are at 58%. And if you could go by county, then you find that there are only around 4 counties doing 100%, and that is Isiolo, Kakamega, Kitui, Nandi, and Nyamira. And you can see for Kakamega, it could be an issue because previously this was a USAID supported county, and only as at now, we only have one facility allocated the KP dataset. So that is, if any participant is in the meeting from Kakamega, I think we need to identify and map the remaining facilities onto KHIS that are offering KP services. So we have counties that are still doing 0%, like Garissa. Meru is doing 4%, sorry, 0% reported for KP. Homa Bay 25%, Migori 14%, Nyandarua 15%, Bomet 9%, Kajiado 5%, Kericho 12%, Lamu 2%, Tana River 9%, Mombasa that 3%, Mombasa doing that 3% with around that 3 facilities offering KP services. So you can see the county with majority of facilities or stand-alone dices that are offering KP services, but are very low or low reported. So we have counties like Siaya, which have 15 reporting sites, but at 92%. So you can see Reporting rate is still an issue on KHIS, and we need to address that. When we look at the VP data set, again, we have an issue. Nationally, we are at that 7% report rate, and you can see county still struggling with the only Marsabit doing 100%, and Siaya doing 99%. So this, remember, this is an average report rate of January to June 2025. Again, we have counties that are still doing 0% from Elgeyo Marakwet all the way to Kisii. Wajir, West Pokot, and West Pokot still doing, and even Nyeri. No, Nyeri is doing 2% for the vulnerable population. There has also been an issue on KHIS where counties are allocating these data sets. Remember, like a county is implementing KP, so it needs to allocate the KP data set, but you find them allocating a VP data set. Again, so we need also to be careful when we are allocating those data sets at county level. Let's ensure that we allocate the correct data set. So you find a county like maybe like Migori allocating, maybe they wanted to allocate a KP data set, but you find them allocating a match data set to a facility. So we need to be very, we need to determine and be very sure that we are allocating the correct data set for the correct typology of programming. So this is MH 739C. Nationally, we expect 499 facilities to report on that data set. And remember, if you've been allocated 739C, then you need to allocate again that one for VP or 7 that one for KP. But you find that for KP, we had around 537 for facilities, but 739C we have 419. So it means we have facilities that are either doing VP or KP services that have not been allocated the 739C data set, which again we also need to address. So you find that we only have Nandi, Kitui, Kirinyaga, and Nyamira doing 100% reported for this data set, while the rest of the counties are still struggling with Isiolo, Mandera, Marsabit, Tana River, Nyandarua, and West Pokot are doing 0%. So this, as a result of those reporting rates, and again, as a result of disruption in funding, you find that if you have to run trends, like we are looking the quarter ending December 2024, and the quarter ending March 2025, and the quarter ending June 2025. So you see, like for out of an estimated population of FSWs of around 285,000, then you find that in the quarter ending December 2024, we were able to reach 208,945 FSWs. But you look at quarter ending March 2025, we have only reached 151,151 FSWs. And then the quarter ending June, we have reached 155,442. So you realize that in the quarter ending March, we have lost 28% of these FSWs, and in the quarter ending June, we have lost 25%. For MSMs, we as at December 2024, we had reached a total of 87,558. But the quarter ending March 2025, we lost. We are at 49,000, and then the quarter ending June 2025, we are at 58,000. So giving us a 44% and 3% loss respectively. For the PWID, we were able to reach 21,000, the quarter ending December 2024. The quarter ending this January 2025, March 2025, we were able to reach 16,000, a very drop of around 25%, and then a drop of 38% for the quarter ending June. where we were able to reach 13,506. And then for the transgender population, this has been majorly affected because you can see out of an estimated population of 7,521 nationally, we were able to reach 4,855 in the quarter ending December 2024. But now we have dropped by 50% the quarter ending March 2025 and 44% the quarter ending June 2025. So when we look at even positivity trends per KP typology in these respective quarters, you can see FSW a slight drop. So for FSW, there is a drop in positivity if you compare all the quarters. And then for MSM, again, at the quarter ending December at 24, we were at 0.3% positivity, then a slight shoot to 0.8%, and then again a drop to 4.9%. Then PWIG, it dropped and then rose in quarter ending June 2025. And then for TG, it has also been dropping from that, from 0.5% to 0.43% as at the quarter ending June 2025. So when you look at the trends of key populations on ART, October, for key populations on ART, you can see for the quarter ending December 2024, we were reaching 20,934 FSWs on ART. But now by the quarter ending March, we lost 24% of them. And the quarter ending June, we have lost 19% of those clients. For MSM, we were reaching 5,513 as at December 2024 on ART. But for the quarter ending March, we have lost 20%, and the quarter ending June, we have lost 10% of those clients. For PWID, we were reaching 880 as at December 2024, but we have lost 29 and 51% as at June 2025. And then for TG, again, that 5% loss and 13% loss in the respective quarters. So when it came to MAT again, this is where we are saying counties are allocating data sets to facilities that could be not offering MAT services. Like for Nairobi, Gidororo Runda Baptist Clinic, I doubt if it's doing MAT, but when you run this report on KHIS, you find that it has been allocated that data set. So just let's be careful to ensure that when we are allocating these data sets, we allocate the correct data set, because again, that now has an implication on the reporting rates at national level. So you can see for March as at June 2025, we are doing 71%. Then ever inducted again, because of those report rates, you can see again a drop on the currently on March from 3,800 to 3,500 as at June 2025. When we look at vulnerable population again, so for vulnerable population, they receive these services on biannual basis, that is 6 monthly basis. So if we do their report for January to June 2025, then you can see that for fish, we are able to reach 49,000. The quarter ending December 2024, the quarter ending March, we were able to reach 22, and then the quarter ending June, we were able to reach 30,000. For inmates, we have improved because we started with 545, then an improvement to 1,202 as at June 2025. Trackers, we are dropping. We started with 13,000, in the quarter ending December. Then we dropped to 9,000 the quarter ending March 2025, and as at the quarter ending June 2025, we were at 6,359. There is no reports about discordant couples on KHIS, and we need to ask ourselves whether there are counties that are programming for discordant couples and have not yet uploaded the reports for discordant couples. The positivity rates, this is Jan to June 2025. For fisher folk, we are at 0.3%. In inmates, we are at 1.3%. So that is the highest among the vulnerable population. And then trackers, we are at 0.2%. And this is no report on KHIS. And this is trends of ART for vulnerable population. So you can see for fisher folk, a slight improvement because now we are at 5,000 as at June 2025. We started with 4,912, a drop, then 4,821, then again an increase to 5,096. These are fisher folk currently on ART. For inmates, again, it has been a rise. We started with 174, then 781, then 992 inmates are on ART. Again, trackers an improvement from 29 to 72 as at June 2025. So that is a snapshot of data on KHIS, and you can see when we are losing clients on ART, then especially who are key populations or vulnerable population, then that becomes a concern to the national program because we will not be closing the tap of elimination. So that is all from my side. I could ask if there could be any questions before Dr. Eric takes over with MH739C. Back to Mbao.
Vincent, for the walkthrough, because in depth, and we really appreciate. Do we have any question? I think we can allow Dr. Eric to come in, and then we can have a final session of question and answer. Dr. Eric, in the interest of time, I realize that we are already at 11 a.m.
Thank you, Mbao. Mine will just be brief.
Dr. Eric Mutua, if you can.
Can you hear me?
Yeah, we can hear you. I think it's my mic that, my volume that was low. We can take, you can have a chance and then we take the questions in unison and answer.
Yes, mine is just, before I present the 739C, is just to applaud the initiative to bring the entities, the people who are involved in this data, handling of this data. And I think of importance is something which Vincent has just said about the outreaches. So I know in the last distribution of STI commodities, there are some facilities which received drugs for STI, and maybe there was no prior communication on what was supposed to be. And I had hoped that Mbao, you would have talked about it, whereby there are some diocese which had selected facilities where they go and conduct their outreaches. So they wanted those drugs to be delivered to those facilities to make sure that when they go to do the outreaches, the data is captured under those facilities. So I hope you'll make I know it's Jeffrey who did it, and I think he shall be able to clarify on the same. Allow me to share my screen. I'll do it. It's on a PDF form, so let me just share it where it is. 1 minute. Why is it not displaying? Just a minute. So confirm whether my screen can be seen.
Sure, Doctor. We can
Yes,
see.
yes.
Yes. So we have this FCDRR for lubricants, needles and syringes, STI and hepatitis B commodities. Actually, it shouldn't be hepatitis B, but it should be hepatitis commodities. I think we were in the spirit when we were trying to do these things because now we can see integration is happening. And this is how this register looks like. I know it was distributed to some diocese. The diocese which received these are in Makueni, Machakos, Kitui, Nairobi, and Kisumu County. For the rest of the other counties, the registers are at NASCOP, so you can make arrangements to come and pick them. I also know that Kenya Red Cross picked some of these registers and they distributed to their diocese. So mute somebody, there is somebody talking. So this is the register, how it looks like. We have the lubricants. We have the unit of issue, which is in form of sachet. You have the beginning balance. That is column A. Column B is what you have received. Column C is what you have issued out. D is any losses and wastages. And then there is the E and F talking about the adjustments. Then we should have the end of month, the physical count of what is in the facility. And then you have column H, which is talking about the days in which you are stocked out of these commodities. And then there is, kindly mute somebody.
Mercy, you can help us to mute the one who is using Techno K15. I think it doesn't have a name. Kindly.
Just the introduction. So if we do it first, treatments are advanced.
And then we have the quantity required for restocking. So we have the needles and syringes, that is the NSP1 and NSP2. I know if your facility does not have any of these, you should just put it as 000. And then we have the overdose. I know overdose it's supposed to be naloxone only. The naloxone either the prefilled or the naloxone ampule. And then the naltrexone, buprenorphine, they are supposed to be at OST. But as it is right now, we are not using this register for reporting of any OST medication. So these are just there, so we shall make the amendments when you are revising the register. And then we have the STI commodities. We have listed them there. And then we have the hepatitis, that is B and C. We have the screening test kits, and we have the treatment. Again, we will amend or revise this to reflect the current hepatitis C treatment, which will be sofosbuvir, daclofenacin. That is what we shall be having moving forward. The other two are no longer being procured. And then you are supposed to just sign off as the other registers. So we are requesting for sub-count pharmacists to assist and ensure that the diocese are able to fill these registers. So even as you are doing your monthly reports, we really request you to also patronize and ensure that the diocese are also reporting on the same. And I remember during the last meeting, I don't know, it was sectional, not all the diocese were involved. I joined one which Kenya Red Cross had invited their respective diocese. And we said, moving forward, we don't want to continue doing the push like we did last time. We did the push and we will no longer do the push. We want to be doing now the pull system. I think there is also condoms somewhere. This mine, I think, is not the most updated. We have condoms, male condoms. So you should also report the male condoms, the quantities required for resupply and what you have in the facilities. So we have said moving forward, we will not be doing a push. We did the push because of the downtime of KHIS in February and March. But now moving forward, we shall just be pulling, Vincent will be pulling this data and allocation will be done according to this. And in the near future, we are going to embed this in the KEMSA LMIS such that when allocations for ARVs are being done, the same allocations will also be done for these commodities. So we really need people to start reporting, because if you will not report, you will not be getting your commodities. And I know you will do a lot of emails and SMSs and calls, but we need to start being accountable of what we receive. So that is what I would urge us, ensure we embrace this. So for the facilities or diocese which are yet to get this, I know the PEPFAR sites, most of them have not yet received these tools. So we shall liaise with them and make sure they collect and then distribute to their respective diocese. Thank you.
Thank you, Daktari. I think we can move to the section of questions and answer. Jen Geshoro, confirm you can hear me and you're able to help us take questions and coordinate the responses.
Yes, Bao, I can hear you.
Thank you. Mike, we can take questions and both in chats and verbal, and we can see if we can be able to respond. Jen, you have the mic.
Yeah, thank you, Bao. Thank you, Dr. Eric and Vincent, for the nice presentation. I think it's now time for Q&A, and so maybe either we raise our hands up or we just unmute and speak, as long as you're not speaking more than one at a time. Thanks.
So I think, Jen, there are questions on the chat, so you can go through the chat. I can see some questions on the chat.
Yes, true. There are questions on the chat, and I think one of them is, please, John Bao, comment on the functionality of prevention KVP module in Taifa Care. I think I've started from, that is one question. There is another question from Jao Shege, who is asking who exactly was trained or sensitized on the revised tools. It appears that KP focal persons were left out of the process. With a more inclusive engagement, we would expect significantly fewer gaps. I noted the gaps moving forward. So who was trained? I think that is a question maybe to either the program manager or even the data person, that is Vincent. So maybe you can have those two tools. I mean, the two questions about the functionality and who was trained. And maybe if there is anyone else with a question, we can put our hands up. Maybe Vinny, you can answer to the second question.
Yes, so training for these tools happened majorly it was Global Fund counties where they were able to train comprehensively. But remember, this was the time when we had a shake-up with the PEPFAR. But currently, counties are we trained CASCOs for some of the PEPFAR sites, and they were supposed to cascade the training at county level. But you realize because of that shake-up. But I think now we are stabilizing, and partners need to take up and ensure that CASCOs or the counties are facilitated to cascade these trainings at county level. It can be, we can also do virtual trainings at requests, like I can see Nairobi is scheduled for training. So it's something that is continuous because we realize that because of these funding cuts, the trainings that have been usually happening at those conference trainings have really scaled down. So we need to come up, if you request for online sessions, we are available. And even for the TOTs that were trained to cascade the training at county level. But it's county-based. As I say, counties are requesting for trainings at different periods. What we need to do is to fast track and ensure that we saturate the trainings across the country. So for Taifa Care, I think this is a different. We are planning for sensitization through Palladium, and I think these are some of the issues that will be addressed. Remember, the KVP module is not fully functional in the 3.x module. There are still some hiccups, and there are things that we are NASCOP SI is addressing with the Palladium, and we will have a virtual sensitization of the same when it comes to EMRs with regard to KVP.
Thank you, Vincent. There is a question from Shikuku, is asking whether we are able to specify the DICE, the link facility where the two SLS reporting at the same facility. I think that can also be addressed by Vincent. I don't know whether you're able to tease that out.
Yes, yes. Okay.
Yeah.
Oh, go on, Jen.
You're able to mention the two facilities?
I've not gotten the question clearly. Are you asking
yeah, it's
where?
In the chat. From Shikuku. Maybe Shikuku, you can raise your hand up and ask the question. Maybe I just leave it as it is. Is it possible to specify a particular DICE under the link facility where there are two? Yeah.
Hello.
Shikuku, you are talking?
Yes.
Please ask your question.
Okay, here comes a case whereby maybe under a one link facility, we have two SRs that are reporting to the same link facility. So we have IRDO and we have MEGO. So I was asking if in the KHIS, can we differentiate like this one is a data set for like, we know that maybe the 731 or the 739C. But now when you go under that particular facility, can it be specified that this is an IRDO and this is MEGO SR?
Shikuku, for that case, it can't be specified. But remember, in that scenario, then maybe MEGO is doing TG and the other one is doing FSW or PWID. So you will be able to get your data because we are not expecting that two partners are reporting in the same facility for one typology. So if they are doing for different typologies, then that is possible because that data set disaggregates by typology. So you are able to see that if MEGO is doing TG, then all TG data in that facility is for MEGO. And remember that data should be prepared at once, because we are expecting that all records pertaining those TG and even FSW are domiciled in that facility. So the HRO compiling the report should do it once, such that one report is submitted at sub-county HRO for data entry on KRCS.
Okay.
Thank you, Vinny, for the response. I think the other one is a comment from Joroge. He's saying that the meeting should have been directed to the health directors and not as them sending the link. I think that is noted for future meetings. That is what we need to do. The other thing is that someone is saying that we might have sensitized the wrong persons, so there's need to recognize those people who are offering services at the diocese. I think this is also noted. I don't think that needs a response. Jao Shege is also saying, kindly clarify the reporting of condoms in MOH 739C. The data set is missing. The condom reporting in KHIS again. So I think Vinny will also take that about condom reporting in 739C. Maureen Wajiko, the biggest gap we are experiencing is the disconnect between the MOH facility, HLIOs, and KP data people. The MOH facility, HLIOs don't understand the new reporting system and are in conflict of why they are reporting numbers and clients are not from their facility. Can they be sensitized first? I think all the questions are coming back to Vincent. Vincent, are you able to respond to those two?
Yes, so the last question, we are saying we are solving that problem by making sure that if you are going to an outreach in a sub-county where this dice is not physically located, then you have a link facility where this should be a KP-friendly facility, where you've selected to be your facility, where when we miss outreaches, then KPs can go to that facility and get service. So there should never be a disconnect, because now the reporting structure has been aligned just like any other data set on KHIS, which sub-county HROs are dealing with. So it's not different. So if it's like maybe Makindu sub-county hospital in Makueni doing KP services, then we expect Makindu sub-county hospital to have all the records pertaining those KP or the VP if it's trackers for that, and they're able to you are now able to aggregate that data at facility level in that tool and forward to sub-county HRO for data entry. So sensitization meeting will continue, and I'm saying because of funding cuts, you'll find that most of them will be virtual. So in case a partner or account reaches for a virtual training, we are ready and we are able to do that training. During my introduction, I said that MOH 730B is where we are expected to report condoms. They were moved from MOH 739C because condoms, remember, is a universal commodity used by even family planning and the rest. So it's not KPs alone who are using condoms. So, and we expect to account for all those condoms, both that family planning and that prevention services. So that's why we are saying the current 739C, you will not see condoms, but you are expected now to report condoms on MOH 730B. So I think Jen have answered all the questions.
You seem to have answered all the questions, because there are questions about clarification on MOH, again 739C and 7, and this one for VP 730B for general population and IPs. I think we need to clarify that again. Who is responsible for uploading 739C at the sub-county level facilities? Can we change facilities that that were located KVP data sets, since we have a private facility called Miamo Hospital in Galeni sub-county in Kilifi County, which want to change to government facility? Are you able to answer those questions? Vincent, I think all these questions are yours. Most sub-county HLIOs and sub-county pharmacies are not aware of these new tools. I think issues of sensitization again will come in. Is it possible for KP data assistant to be able to have the lights and access to the KHIS? Vincent, what are you able to answer? Clarification on the MOH 739 and 730B.
So I said 730B is done by all facilities, whether it's a DICE or it's a healthcare facility where we have integrated KP services, or it's a normal facility, healthcare facility that is not doing KP services. We'll report on 730B because now we are using that data set to report condoms. And then 739C, we are using it to report KP specific commodities that we receive directly from NASCOP. So that one, those include the NSP kits and the hepatitis commodities. And then whether, I think the issue of private facilities offering KP services, maybe John, you could respond on that. For this private facility doing KP services, but my take would be they'll have all the data, and they'll have they need to have all the tools for KP, and there should be no problem for them. There should be no problem. And even if you feel that the facility you provided for as your link facility is not the right facility because we expected them to be KP friendly, then there is that option of changing. But we don't expect frequent changes. Like today, you are telling me you are reporting through Bondo Sub-County Hospital. Tomorrow you come, you are saying you are reporting through CIS. So you see, the issue of going facility level was also to ensure that there is that continuity. Like when our partner exits, we are not naming facilities in KHIS after partners, but this should be county-owned data. So, and this should be, the data belongs to the county. So we expected that when dices are being closed because of funding issues and another, or maybe transition of partners, we are not renaming them, like maybe CHS is leaving and CB is coming in, so we need to rename. So those again were some of the why we were moving from sub-county level reporting to facility level reporting. But John, I think you can comment on private facilities doing KP services.
Thank you, Vinny. I think a facility, as much as it has an MFL code and a county and a county arrangement, that is with the CASCO and the CHRO and the county pharmacists, if they're able to agree on allocation of data sets, then the question of the day would be KP's VP is able to receive service in that facility. And if the answer is yes, then there should be no challenge into having that proceed, as much as there is a concurrence with the county. But however, if the county feels then they need to do the reporting in a link facility, then we leave that at the discretion of a county, but being available to support even in case the private facility has an MFL code but doesn't have a data set. I think that should suffice.
Thank you, John.
Thank you, John. And I think the questions are many. Someone is asking whether they can have access, light to access KHIS as assistants. I mean, the data assistants, can they have the lights to do that? There's a request that we need to build capacity to the county, sub-county HLIOs on some counties, I think it's good for them to reach out and different counties need to reach out, those who need sensitization. I know, like Vincent has said, that is possible to organize. So we are advised to take reports to each department, like issue of cascading the reports. I think someone is asking whether it's possible to have a follow-up on the reports. Vinny, maybe issue of access to the KHIS.
So access rights, view rights can be given, and even this, even at county level, just requesting your county charo, sub-county charo, you are able to get view rights. But data entry rights, again, is at the discretion of counties. Certain counties will give data entry rights depending on the local arrangement with the partner. So that is something NASCOP have no control over, because health is devolved and counties are able to organize themselves. If a county feels they're able to give data entry rights to their partner, then that is well and good. If they feel that all reports need to be aggregated and submitted to the sub-county charo for data entry, again, that is still a way that we can use to ensure that reports are entered onto KHIS. But for viewing rights, this has been given especially for the M&D persons of diocese and even people working in health, or other partners working in health. Once they request for view rights, they are usually granted.
Thank you, Vinny. I think there is a question about, let me just read it as it is. We were advised to take the reports to each department, like the 739C to pharmacy 643 to lab, but the CASCO laws are finding this difficult since they have to follow up on the reports. Can all these reports be submitted to CASCO laws first to ensure entry?
Jen, you are missing Karen Dongo and George Nyanaro, who have raised hands. If you may consider.
Their hands are up. Wow, confirm there is someone whose hand is up. I can't see.
There is George Nyanaro and Karen Dongo.
Yeah, maybe as before we let them talk, let's look at the issue of this CASCO laws having the reports, whether they can have entries to the reports. Vincent.
So this you see, lab reports. Lab reports surround around lab commodities, and even 739C is a commodity tool. And Dr. Eric has rightly guided that for 739C, it's sub-county pharmacy. Let's follow the already existing structures of reporting at county level.
Thank you, Vincent. We have Carol Dongo. Maybe Carol, you can go.
Well, thank you, Jen. Do the private facilities have access to KHIS, or they have to go through the facility? Because given the funding cuts, you'll find a number of KPs and also VPs, including trackers, may want to visit private facilities, and in the event that is not factored in, we may lose data, especially for KP and VP, especially given the funding issues that we have. So I have heard Vincent mention that health is devolved, so a lot of rights is county-based. Perhaps maybe to hear from the counties, how will it be like for them to give access to private facilities, or they report through them, especially when it comes to KHIS? Thank you. I am Karen Domo, working with long-distance truck drivers. Thank you.
Thank you, Carol. I think we have George Nyanaro. Yes, George.
Thanks, Jen, for the opportunity. And thanks, Vincent, for walking us through that. I think it's really important. So mine is, I think, Vincent, you tried to touch on it briefly, but with the current transition and discussions around integration, even some of the diocese are now, we are moving them to facilities. I think this is in line. But my major question is around the tools. I know you indicated that there are tools at NASCOP that needs to be picked and all that. So there were discussions around the use of AIR, the automated indicator reporting from the Taifa Care to KHIS and all that. I don't know whether this is being considered, considering that now we've seen dwindling resources around the funding, so that we can also reduce the burden of reporting, the manual way of actually extracting these reports and ensuring that is done. I know you partly mentioned that we've not conclusively closed that in terms of the HMI system, but I think for me it would be nice to just push for that, so that therefore, as people discuss around integration and use of the Taifa Care facility-wide, then we are able to automatically have that data from the EMR to KHIS and reduce the burden of either printing or the burden of having extra human beings to extract the report and push. And also we know the issues around transcription issues, so it will address a lot of issues around that. And lastly is about how soon can we have this harmonized in the EMR, because for example, in most of the facilities we operate in 100% EMR covered, so that we don't have parallel paper systems. Thanks, and over to you.
Yes, thanks, George. Vinny?
Thank you, George. I think you've guided well. So we are still following up with these issues of interoperability between systems to ensure that we are able to push reports directly onto KHI. So that is still a conversation in process, and I cannot give a conclusive answer in this meeting, but I promise to follow up with the relevant through the NASCOP SI lead to make sure that even the KP, I'm very much aware that even the KP module in Kenya EMR still have some challenges. So there are things we need to follow up. I think Carol had asked about private facilities having access to KHIS. Yes, these private facilities, Carol, submit reports just like any other facility to the sub-county or to the county where they're supposed to submit. So I'm sure they can have KHIS view rights, but they won't be given data entry rights. So data entry rights remain the majorly under the sub-county HRO, and maybe on local agreement terms, they could be, depending on the relationship with the county or depending on the interaction they can access. So remember, private facilities also just report like any other facility to government. So they need to report, and there's nothing that is hindering them from reporting. And they also have the tools for all the tools that are required for each and every programming.
Thank you, Vincent. I think the last question is about commodity received in sub-counties. Are there any directive on received commodities in a sub-county hospital where the facility has similar commodities that are being charged? That is coming from John Otieno. To me, it's not very clear, but I don't know whether Vinny. This is for Dr. Eric. Yes.
Yes, I think, Jen, I can agree with, and I think this is a dilemma we have been facing for the longest. You know, these STI medications are the same antibiotics and protozoa and phagos, which are still in the facilities. So I think what George is asking, how are we going to differentiate what comes under global fund funding and what the facilities may be buying through FIF? So I think this now calls for the data capturing at the facility level. And since these drugs, I know they will not be dispensed throughout the month, because they may be just, they are just issued when there is I think an outreach. I think the facility and the diocese should just get in touch and sit down and see how they will be able to handle that case. We can't prescribe the how, but I know at the facility level they can be able to just see how it is workable.
Thank you, Dr. Eric. In your when you're sharing, you told us that it will not be push system anymore, rather a request from specific facilities. So does this then mean that you only supply the facilities as they request, so that now they are able to I know it also depends on whether the availability of the same commodities from the government, but they should also be able to request what they need and maybe understand what is being charged and what is not being charged. If I'm not confusing them, that is what I've understood. And I hope the person asking the question has also gotten the answer. So I think there being no other question and time not being on our side, I want to return this meeting to John to close the meeting for us. Thanks.
So thank you, Jane, and thank you, colleagues. Of course, for the clarification of what was not clear and the comments we've taken therein. We really appreciate that counties and facilities are the service delivery points. So really, if there are gaps and issues that need to be sorted and they're not sorted, that means that I really appreciate colleagues for having comments and to ensure that are raised here. Then, of course, we're able to improve our action points that we will need to be actioned. I want just to ask if we have the chair of the county pharmacists around. Dr. Eric, if Dr. is around. I know we missed them when we were starting.
That's how we get the value of assets.
Okay, someone can mute Rachel Gedenji.
We are still going back to the policy. Your policy on the
I think if not available, then do we have a CDH?
We have so many types of things. We have state line, we have reducing,
so we will call it a day. One or two, three action points. We are really concerned when we lose cohorts of clients on ART and we are not able to get that at the national level. So then the question becomes, if they are not on top, then what is happening?
In your books,
I say if you can be able to get the person who is unmuted. Masinyako.
This one I'm giving you to help you acquire more assets. We are intending to use this TV for 3 years. By the third year, we'll depreciate it to 0. So if you figure the third year, remind the donor that the TV that we bought.
Okay. So one that we want staff to follow up on the clients that we have lost for follow-up, ensure that report we're able to get it upwards, because then If we have lost follow-up such clients, then Vincent, if you can be able to talk to us, mute the two people who are muted. I'm really okay. So I was saying that you're able to follow up and ensure that the cohorts are reported upwards. Really, the question that we have in the question that we are unable to answer is for those clients who have lost follow-up, then what is happening to out here in terms of prevention? Because then are we really following up on virus suppression, and are we having
the members can use it?
Transmission happening around? The other thing that we want to see is that for the reports that have not been uploaded, we want to kindly request that we go back and we're able to upload the reports. Thank you very much. We're able to
I think we've lost John, or maybe someone has.
sorry, are you able to hear me now? Sorry.
Yeah.
Thank you for the muting. I think I'll repeat what I said. One, we are really concerned when you lose the clients as per the presentation, the numbers for those who are on ART especially, because then the critical question that we ask ourselves is for these clients that we are not following up who are HIV positive, what is happening in terms of prevention and virus suppression? Is there anything happening around that? Then it becomes a critical question that can only be answered by us tracking and being able to get the cohorts and report upwards. Because then if we don't have the report upwards, then at the end of the day, we could be having quite a number of new infections that might be coming down at the county level and scaling up to the national level. So really requesting that we are able to track that and ensure that we make reports of the same. For the reports that we have missed, both for commodity and KPVP, we request that for the months that we could have not reported, having gone through the sensitization, then we request that we are able to report. We will be expecting this to be actioned. Probably we can give ourselves 2 to 3 weeks. Then we're able to review the the performance rate in terms of reporting as it communicates to the national performance of the program. 3, on the issue of interoperability of the system, Taifa Care, KRCS, and Kenya MR, we are really, we will be following up. We will communicate as time goes by. I think having said that and having been on the meeting for, I think, almost 2 hours for now, I want really to appreciate all of you, the county pharmacists, our facility people who do the hard job of reporting, our CHRIOs. I have seen the CASCOs joined as we are continuing, really to appreciate the support that you people give to the national program, the work that you do day in, day out of collecting data and ensuring that it's reported upwards. Then it is not in vain. We appreciate as that is what is able to inform our our report, our programming and the decisions that we make at the national level. So allow me to say that once again, asanteni sana, wish you a good afternoon in the interest of time so that we are able to allow people to go back and engage in other activities. Asanteni sana and koheri, and we'll be checking into what will be coming up. Goodbye.